Welcome back to The Explainer. Today, we're tackling something really critical for any of us working with bipolar disorder: clinical staging. And let me tell you, this concept, it's a potential game changer for how we think about prognosis and treatment.
So let's start with the question we've all asked ourselves in the clinic, right? Why is it that two patients, both with the exact same diagnosis, say bipolar 1, can have such incredibly different outcomes? You know the story. One person responds well, gets back on their feet, and the other, well, they seem to be on this downward slope. And this isn't some new mystery. This puzzle goes all the way back to Kraepelin.
So how do we get a better handle on this complexity? Well, turns out we can borrow a really powerful idea from other parts of medicine: clinical staging. If you think about it, oncology has the TNM system, right? It's a roadmap. It tells them where things stand and where they might be going. What if we had something like that for bipolar disorder? A framework to map out this super variable illness. All right, here's how we're going to break this down. First, we'll really dig into this problem of heterogeneity. Then we'll look at 3 different ways to think about staging. After that, we'll get into the evidence, what the data actually says. And finally, we'll pull it all together and figure out what it means for us in the clinic.
Okay, first up, the problem of heterogeneity.
The issue here, the real challenge, is that just saying bipolar 1 or bipolar 2, it just doesn't cut it. It doesn't tell us enough about the patient's actual journey. And look, this isn't just us saying this. Go back to 1921, and Kraepelin himself was writing about it. He saw that the course of manic-depressive insanity, as he called it, was just all over the place, totally unpredictable. He knew some patients bounced back completely between episodes, but for many others, it was a much rougher, more deteriorating path. It's the exact same problem we're wrestling with now. So that brings us to the next big question. How do we start mapping this out? This is where we get into 3 different lenses on staging. These are models developed by different research groups, each giving us a unique angle on how this illness progresses. Okay, so let's look at these 3 models side by side. You've got Berk et al., Kapczinski et al., and Duffy. Berk's model is, pretty straightforward. It's all about episode recurrence. How many episodes, how often? Then Kapczinski's model, this one shifts the focus. It asks what's happening between the episodes. It's looking at that cognitive and functional decline. And then there's Duffy's model, which is different again. It takes a developmental view, looking at family history and how the illness starts out. Let's zoom in on Duffy's model for a second, because it's super useful, especially with younger patients. It basically suggests there are 2 different tracks. On one side, you have this classical bipolar disorder. It's episodic, patients have good remission, and they tend to respond well to lithium. But on the other side, there's this bipolar spectrum disorder, and this one looks different. It's more chronic, remission is poor, you might see more psychotic features, and this might tell you something about how they'll respond to treatment. Okay, so these are interesting models, right? But are they just nice ideas, or is there actual data to back them up? Let's get into the evidence, because this is the part that takes staging from just a theory to a tool we can actually use. Let's start with a number that should really make you stop and think. 43%. This comes from a huge study by Talhin and his team, and it points to something absolutely critical we have to remember. Getting rid of symptoms is not the same as getting back to normal life. Here's the full quote, and it's a bombshell. In the 2 years after first manic episode, get this, 98% of patients had what we'd call syndromal recovery. Their symptoms went away, but only 43% achieved functional recovery. Less than half got back to their old job, their old life. This is a massive piece of evidence for Kapczinski's model, right? It shows that functioning is its own separate, crucial thing to track. And this chart here really drives the point home. This is from a study by Ross et al., and they specifically tested Kapczinski's model. They used the FAST scale, that's the Functional Assessment Short Test, and look what they found. A clear, step-by-step increase in impairment as you move from stage 1 up to stage 4. The people in the later stages were doing significantly worse than those in stage 1. It's proof positive that this functional decline is a real, measurable part of the illness progression for a lot of patients. And it's not just about what we see clinically. The biology is telling the same story. When you look at the biomarkers, a major review by Gruel's team found a consistent pattern. In later stages of the illness, you see more inflammation. Things like IL-6 and TNF-alpha are up. At the same time, neurotrophic support, like BDNF, is down. It really suggests there's a biological process happening here, a kind of neuroprogression. That's like wear and tear on the brain, which perfectly matches the clinical picture. Okay, this brings us to a really, really important question. We have Berk's model, which is all about recurrence, and Kapczinski's, which is all about function. Are they just two ways of measuring the same thing? What happens when you actually put them head to head? The answer is not even close. A study by Vandermark's group did exactly this. They compared the two models, and the correlation they found was 0.21. That is incredibly low. And this is probably one of the most critical findings in this whole area. It tells us these models aren't fighting for the same spot. They're measuring two different things. For us in the clinic, that means just counting episodes tells you almost nothing about how your patient is actually functioning in their life. So, where does all this evidence leave us? Well, it doesn't mean we have to pick a winner. In fact, it's the opposite. It points us toward a path of integration, of bringing these different views together. So, if you remember just one thing from all this data, make it this. Recurrence does not equal functional decline. They are not the same thing. Counting episodes is important? Of course it is. But it doesn't tell you the whole story about whether your patient can hold down a job, keep their relationships going, live their life. You have to assess them separately. The way forward, then, has to be this kind of integrated model. And in practice, it means we need to be tracking three things. Step 1, the core mood stuff, the episodes, the patterns. That's your Berk and Duffy model. Step 2, what's happening between the episodes, the functional and cognitive side of things. That's your Kapczinski model. And step 3, you have to account for comorbidity, both psychiatric and somatic, which is a key part of both the Duffy and Kapczinski model. So really, this is about a new way of thinking in our day-to-day work. The evidence is pushing us beyond just a single label. It's asking us to use this staged, multi-layered framework for every patient. By consciously looking at mood, at function, and at comorbidity as separate things, we can get a much clearer picture of prognosis and tailor our treatment so much better. And that leaves us with the real challenge, right? The question we have to ask for every patient we see. What is their stage on each of these different dimensions? And what are we going to do about it today?